Hello, hello, hello. Who's here? Let's see if anybody's here. We have a couple people. Okay, let's go ahead and start, and hopefully people will funnel in. Those of you who are here, please type something in the chat to let me know that you exist. I had to make another link, so let's just see. Maybe people will show up. That would be awesome if they do. I am going to share my window here. Let's share this one, I think. And I was trying to figure out how to get on live. We're going the Psych and Neuro, and I think you're just going to love it. So the idea that I have here is that we're going to go through different questions, and I'd love you to go ahead and make any comments that you can as we go. So here is our case one. Hopefully you can see it. I'm going to make this bigger. Okay. Which recommendation is most appropriate? Always read the question first. Read through the options. It narrows your focus, and then go to the case. So the steps that we take. Which recommendation is most appropriate? Am I screen sharing? Oh. Does that show you anything? It says that I'm sharing this tab, but I don't see it. Does anybody, hey, put a chat in there. Let me know if you're seeing my screen. It says I am sharing this tab to YouTube Studio. Do you see the screen that says case one? I'm putting a question mark in there. Anybody else? Do you see the screen that says case one? No. PharmD, why can't we see that? Okay, I'm going to get out. Oh gosh. I'm live and there are people here. That's amazing. Okay. Do you hear me? Do you hear me? Yay! You hear me. All right. This is saying webcam. I don't know if, well, anyway, I'm going to try to screen share again. I'm going to share my entire screen, all right? Ha! You can see my screen? Can you see repeat me? Can you see me over and over and over again? And I'm so sorry that you're seeing me too much. All right. You should hopefully still be able to see my screen. All right, I think it is working. Okay, here we go. Drive. Going on to my drive, going home, and okay, if we can do it once, we'll be able to do it. This is ridiculous. Here we go. So here we have a case. Now, I'm going to make it a little bit bigger. Okay. So always start with the question, which recommendation is most appropriate? Go ahead and scan. If you need to zoom in on your end, go ahead and zoom in. We have a patient profile, their medications, and objective data. And whenever I am not able to zoom in, you're not able to zoom in right now. Okay, can I read some of it to you? So this is JM, a 42-year-old male, no known drug allergies. He has treatment-resistant schizophrenia, tobacco use disorder, chronic constipation, stable for 3 years on clozapine. Okay, admitted with pneumonia 5 days ago. He has new symptoms: marked sedation, drooling, dizziness on standing, mild confusion. Here's his meds: clozapine, 200 milligram POBID, Docusate, polyethylene glycol, PRN. Inpatient, he was on ceftriaxone and doxycycline, nicotine patch, enoxaparin. He socially smoked 2 packs a day at home. Okay. QTC 438, white blood cells, no rigidity, no fever. Okay. I'm seeing an answer from somebody as E. Let's go take a look at E. Add benztropine because the drooling and dizziness are extrapyramidal side effects. You know, I really think of extrapyramidal symptoms more as movement issues. So like the tremor or rigidity or dyskinesias. Let's try to look at some of the others just to look through all our options. Anybody? Oh, you're not able to hear now. Are you guys able to hear? Anybody who's there? Okay. Shy, I see you chose C. Can you hear me? Yay! Okay. Oh, and Brenda cannot. Yay! Okay. You guys are the best. Okay, let's check out C. Temporarily reduce the clozapine dose and monitor for toxicity due to loss of CYP1A2 induction. I need to hear a little bit more about that. What are they talking about here? Temporarily reduce the clozapine dose and monitor for toxicity due to loss of CYP1A2 induction. Sounds like some drug interactions, right? What would be doing this induction? Remember that induce would be to decrease the level of the substrate, in this case, clozapine. And they're telling us that clozapine is metabolized by CYP1A2. Is this patient on any inducers, including social history? Yes, smoking. Okay, what happened? He was smoking 2 packs a day at home, and then suddenly he's admitted and no cigarette since admission. Even though he was on nicotine patch, that doesn't matter. There is going to be an abrupt discontinuation. So that initial, him smoking 2 packs a day, we monitored the clozapine, got the levels right, and now all of a sudden he doesn't have that interaction anymore. So we would see toxicity. So that was a great answer. C is correct. So cigarette smoke induces CYP1A2. Stopping cigarettes can raise clozapine levels within days. So we had these traps. Nicotine replacement does not replace CYP1A2 induction, just like I said. Tempting. A was tempting because infection may destabilize psychiatric illness. But the signs are toxicity signs, not psychosis. Nicotine replacement helps withdrawal, but does not replace cigarette smoking. Enzyme induction. D, ANC is acceptable. This is not neutropenia driven discontinuation. Benztropine treats EPS. It can worsen constipation, confusion, urinary retention, and anticholinergic burden, but it did not describe the drooling. It didn't describe the symptoms that they were talking about there. So that's why E was incorrect. So what I put up here was our substrates on the left that are the most important 1A2 substrates. Theophylline, or warfarin, not the strong one, and clozapine. Smoking is an inducer. It's part of PS porks. And ciprofloxacin is an inhibitor of clozapine and theophylline and warfarin. Let's do case 2. So this is our trial to see if our YouTube works. And I think we can do that, continue to do this if it is working and if you guys are actually responding and looking through the questions. So we have this new question. Start with the top. Which anti-seizure medication is most likely responsible for treatment failure? Scan through your options. I do see all the options as anti-seizure medications. Now I want to see what they're talking about by treatment failures. And if you're studying this on your own and looking through it, you can mute me as you go through this. But I'm going through this to show you the steps that you should take so that you don't get confused with all the data. So treatment failure, let's look and see what the treatment was for. We do have some allergies. This patient has AFib, hypertension, focal seizures, osteopenia. Started anti-seizure therapy 3 months ago. Now presents with ischemic stroke. Patient and pharmacy fill history confirm adherence to apixaban. This patient was adherent to apixaban. Medication was apixaban, lisinopril, atorvastatin. We did have a new anti-seizure medication started 3 months ago. No missed doses, no renal dose issue. MRI, acute ischemic infarct. What could have happened? Which of these drugs? They're asking, this patient got a new anti-seizure medication. They didn't tell us which one it is. They're trying to ask us which drug could it have been. Is it true that levetiracetam is renally eliminated and there would be a need for dose adjustment? What do you think about A, you guys? Go ahead and type it out. Do you like A? Levetiracetam due to renal elimination and need for dose adjustment. Brande's like, no. Shy is like, no. I'm like, no. I just typed into. That doesn't even. Crystal, hi, Crystal Wong. Nice to meet you. Yeah, absolutely no. It just doesn't make sense. We already learned that there wasn't any renal dose issues. Then B, lamotrigine, due to inhibition of apixaban metabolism. Would it make sense that, let's suppose this is a true statement. Let's suppose lamotrigine is an inhibitor. Would an inhibitor make apixaban ineffective or toxic? Could it cause clot or bleed? If you have an inhibitor with apixaban is a substrate, would an inhibitor potentially cause clot or bleed? Yes. So everybody that I'm seeing is so far is saying bleed, bleed, bleed. Great, 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 you guys. It would increase the apixaban because inhibitors heighten the level of the substrate. So that's not what happened here, right? There was ischemic stroke. So B is out. Carbamazepine, due to strong CYP3A4 and PGP induction. Let's ask that question. Do you know of carbamazepine being an inducer? Is carbamazepine an inducer? Shai is saying yes. I don't know who Mrs. G454 is. Is that Tina? I'm not sure. Yay! Okay. Carbamazepine is an inducer. We had PS porks or Surcops, I say senior cops, as a mnemonic for inducers. Inducers do what to the substrate? If carbamazepine is inducer, what would it do to apixaban? Do inducers increase or decrease? So Brenda, I said inducer. Yeah, fast elimination, inducing the metabolism. So if you induce the metabolism, you're quickening the reduction of the carbamazepine in the blood. So the quick way to think about it, once you think it through and understand that it's an actual fact, induction does decrease. So I say induction, and then I remember the D for decreases the level of the substrate, which is apixaban in the blood. So we'd have lower apixaban, increased risk of clot. And isn't that actually what happened with ischemic stroke? So I might hold on to C. I think C is correct, but I haven't looked at D and E, and I've been known, oh, thank you. I've been known to be kind of wrong in the past, or there's a better answer, like maybe like they just say something that's more true. So we have to double check. Gabapentin, D. Gabapentin due to reduced absorption of apixaban. Hey, you guys, real quick, type in, do you know of gabapentin reducing absorption of other drugs? Is that something that stands out to you in your memory? Me either. No and no. Yeah, you guys, me either. Crystal too, no. Crystal, do you have 2 accounts? Are you having trouble getting on? Anyway, good job, you guys, you're right. So far, we're going with C. Let's check out E, though. Lacosamide, due to clinically significant CYP3A4 induction. You should ask yourself, does lacosamide stand out to you as an inducer? You memorized all these inducers, right? You know them. Yeah, it doesn't stand out. And we should do that too. If you don't feel 60% sure or more of an option, don't go with it, because questions are designed to be close to the truth. Otherwise, they wouldn't be good questions. So everybody write down, what is your answer, A, B, C, D, or E? Shai's saying C. Brandy's saying C. And if anybody is opposing the C, let us know because we'll talk it out. C is right. C is right. C is right. Carbamazepine, due to strong CYP3A4 and PGP induction, it is an inducer. Levetiracetam may need renal adjustment, but it's not a strong CYP inducer. Lamotrigine is not the classic interaction lowering apixaban. We were talking about in class, we were talking about lamotrigine earlier and how it's a substrate actually, and that's why we have these different colored boxes for high, medium, and low dose lamotrigine. So I mainly think of lamotrigine as a substrate anyway, so that wouldn't make sense to me. Gabapentin D has absorption interactions with antacids. Not a major apixaban failure interaction, no, like we said. And lacosamide is more interaction sparing than classic enzyme inducers like carbamazepine. Nice job. So this is what I wanted to put up for you. If you put these in order, it can help quite a bit. So if you just say A, B, C, D, try to line these up and go over them a few times, you would know the CYP3A4 substrates. These are the drugs, I call them the victims. They're the victims of the inducers and inhibitors. The substrates are the ones that are going to go up or down in the blood. They could cause toxicity or not be effective, depending on whether they're being taken with an inducer or inhibitor. So as you see in the first one, we had anticoagulants for A, B, C. Anticoagulants for A, apixaban is in there. It is a substrate. You know what else? I'm going to go down here and I'm going to remind you guys that carbamazepine is a substrate as well. So carbamazepine is an inducer, but it's also a substrate. So we call it an autoinducer because it induces its own metabolism. And this is a reminder of CYP450 inducers. Inducers decrease the level of the substrate in the blood. We had a couple different mnemonics. PS porks, spell it out, right? There's our smoking. In that first question that we did, it is an inducer. It would decrease the level. It was kind of a confusing question because smoking ordinarily decreases the level of the substrate. But in that first question, he quit smoking. That's what made it more complicated. Phenytoin, phenobarbital, carbamazepine. All right. And then if you could just rearrange it and you can say CR. So I think of senior for SR, senior cops will decrease crime. They're supposed to. Senior cops decrease crime. So I remember that as inducers decrease. Okay, and next time we'll go ahead and start with case 3. This was a trial run and I love you guys. You guys are awesome. Thank you for answering the questions. We'll get this down pat. You guys let me know. You can message me. Let me know what times are best for you. And we can just continue to do practice questions and keep them going. And cases, plenty of cases. All right? Okay. I hope everybody has a wonderful rest of your night. Bye.